Please, group 1 for the new group, Midwifery Practice Group 2. Midwifery Practice 2, Group 1, kindly send me your work. And you can start projecting. Please, group 1, you can project your work.
Good morning, everyone.
Good morning, sister.
My people.
Good morning. Yes, ma'am.
So while we are waiting for, I hope you are all doing well. And welcome back to another session of the midwifery practice. How was your week?
By God's grace, we are fine. We good.
You sound good. While we are waiting for the group 1 to start their presentation, if you know that you have joined with your phone name, whatever, without your index numbers, you haven't joined with your right name with your index numbers, and then you have your phone names reflecting on the participants list, please advise yourself and rename it before I put you in seclusion, please. And then group 1, finally we are done with last semester's work, and so this weekend is for the new topics and then the new group. So group 1, like Christy said, submit your PowerPoint to her. And then if you have someone to share your slides, please share and then start your presentation. We are waiting. Please don't waste our time. We have a whole lot to do before the semester ends. Thank you very much.
Hello, sister. Hello.
Hello, Shine.
Yeah, sister, please, good morning once again.
Good morning.
Yeah, sister, please, group one, we are not ready with our slides. We didn't know we'll be presenting today. We met to discuss, but we haven't compiled the.
Oh, but how would you not know that you start presenting today? We finished with last semester's work last week, and I think prior to last week's session, your class rep contacted me about your presentations and the fact that you guys were not ready for last week. And I told her that we are still in the last semester's work, so she shouldn't worry. We'll start everything this weekend. So this excuse isn't feasible. You cannot tell me that you are not ready and all that.
Sister, it's not in the PowerPoint. We only have it on the
We have it
PDF.
in a PDF format.
No, but how can you have it in a PDF? Can you present a PDF work to me when I clearly stated that it should be a PowerPoint presentation? Maybe I have to start deducting marks. Once you miss your opportunity, we take the marks and then we allow the next group to present. If that is what will make you sit up.
Please,
Sister,
we beg.
we are begging. If maybe we can present, then later send the PowerPoint.
You can't
to you.
present a PDF to me. You want to make my cocoa pie this morning.
Sorry.
Sister, please, we beg.
If group 2 is ready, they can start. You, the group 1 people, I'll think about what to do too.
Sorry, madam.
If there is any group that is ready to present, they can project their work. Or you are all not ready as a class.
At least,
Please, group 2 are ready. They are projecting their work.
good morning, sisters. Please, we are group 2 and we are presenting examination of the preparatory. So these are objectives and clinical. These are presentation outline. We will be looking at the objectives and clinical significance, preparation and ethics, assessment and examination of the preparatory, clinical prerequisites and checklist, the family clinical memory, and breast and lactation examination, assessment of the uterine founders, the lower extremities and DBT screening, local progression and clinical items, episiotomy and perineal assessment, and in the postpartum guidance and references. So these are the people. Yes. Yes. Our objectives and clinical significance. We said the fourth stage is also known as the crucial fourth trimester. Why? Because the postpartum period or the period, we said it represents 6 weeks of intense physiological retrogressive modifications following delivery, and it carries a disproportionately high risk of maternal morbidity and mortality. So, the first 6 weeks after a woman gives birth, we say it is crucial because even though she has given birth, a lot of things can happen. Our maternal morbidity, such as complications or conditions that arise from the pregnancy, it could still affect the woman, and it could even lose the person. And then the physiological issue, the indication, the person has finished giving birth, the body now has to go back to its non-pregnant state. So with that, a lot of things are happening to our mothers. And we say the key objectives of this session is to identify deviations, that's to rapidly detect complications before they escalate. Complications could be postpartum hemorrhage, it could be infections, it could be deep vein thrombosis, the postpartum preeclampsia, and the pregnancy. And then we track involution. We verify if the uterus is involuting well or not involuting well. And we support lactation by early initiation and then frequent feeding of our babies, feeding the baby every 3 to 4 hours, and positioning and making sure that baby latches well. And we educate our mothers on how to properly breastfeed, not making them think one breast contains water and the other one contains food. So you are teaching the woman all these things to empty one breast before the other. And also we are looking at we are promoting the well-being of the woman by assessing her mental wellness and maternal adaptation. And most of the time, some people, pregnancy is because of the hormones change and all that, it could affect the mother's mental wellness. And you see, pregnancy comes with a lot of changes to the mother. Some will later look at her body and say, this was not the body she had. Some could be having problems at home, financial constraints, and all that. So with this, during the preparation stage, we have to assess all these things. So you are going to the preparation and then the ethics. So with the preparation and ethics, we are saying that we have to ensure maternal comfort, clinical safety, infection control, and absolute privacy during physical examination of the vulnerable postpartum patients. The clinical prerequisites and checklist. We have to take consent and provide privacy. We verify the patient's identity by checking the patient's name and then mentioning her name to identify herself that this is her. We explain the clinical steps to her, the step-by-step procedure that we are going to do to her. We have to explain it to her, and we have to gain her informed consent. She has to consent to it that she has agreed that we should do it. Because sometimes some people come and I don't know, by just looking at you, they don't even want you to work on them. So you have to make sure that you have the verbal consent. And we close doors and we maintain the dignity of the woman. We don't have to expose our preferred women just because we have to do our work. So any setting, we just let them lie down and we start working. That's not how it should be. We have to make sure that we screen them before we start working with them. And then infection prevention. We have to use the strict aseptic protocol of food by washing our hands well, making sure they are dry so that we don't transfer bacteria from our hands to our preferred mother. we know that during preterium, it's not only for mothers who gave birth vaginally. Our CS mothers to our part. So if we don't practice these hand hygiene, we are introducing germs, pathogens, bacteria to their wounds, which will later make the wounds become infected. And during the assessment too, we check their perineal perineum to see if episiotomy wounds are healing or not. That if we don't practice these aseptic procedures, then it means they are going to be infected. And then we are telling our women to also, we are making sure that they empty their bladder first before we start any assessment on them. We request the mother to void before physical assessment. A full bladder displaces the uterine fundus upwards and laterally, impending accurate assessment. So with our peripheral mothers, we know that we have to check their fundal height. If they come and then they feel like urinating or their bladder is full, it will not give you correct findings as to if the uterus is polluting well or it's not polluting well. And then it makes the patient also feel uncomfortable. Yes, so please, my sister will continue from here.
Good morning. So please, we are continuing from the Bubble HE clinical mnemonic. So we have abbreviation for it. So we are starting with the B. The B is the breast. So when the pepperal woman comes, you have to examine the breast for engorgement, nipple cracking, mastitis signs, and successful breastfeeding. So when you see the nipple is cracking, meaning the mother is not breastfeeding well, so you have to tell the mother how to breastfeed, like tell her to push all the areola into the baby's mouth to prevent it. Please, can we mute to prevent any nipple cracking? And we have to also check for signs of mastitis, any redness on the breast, or any inflammation or any pains at the breast. Then we go to the U, that's the uterus. So you have to measure fundal height relative to the umbilicus, ensure firmness and central position. So you have to measure the fundal height to know that indeed the uterus has been involute. So you have to measure the fundal height as well when the pepperal woman comes in your aid. Then the next B is for bladder. You have to confirm from the woman if she voids spontaneously, meaning if she voids by her own, not pushing the urine to come out or something. So you have to check for dysuria or any signs of UTI. Then the next B is for bowels. Assess bowel sounds, check passage of gas or stool, and note presence of hemorrhoids. So I think this one goes to the cesarean sections, those who did the C-section. So you have to ask the mother if there is a bowel sound or if they pass stools. And you have to also notice if there is any presence of hemorrhoids. The next L is for lochia. You have to examine the discharge amount, the color variation, that's rubra, serosa, or alba, and look for clot or any other. Yes, as we know that from the first 1 to 3 weeks is rubra. So after at the puerperium, that's 6 to 8 weeks, you shouldn't be seeing any rubra lochia. So you have to assess for the lochia to know that you are getting the right lochia, the alba. Yes, so you can ask the woman or you have to examine it yourself. Then the next E is episiotomy. You have to examine the perineum using the Rieder scale. That's the redness, edema, hemosis, and discharges. So this one too, I think is good for the those who went in for the SVD, spontaneous vaginal delivery. So you have to, if the mother had episiotomy during labor, you have to check the incisional site to know that there is no redness, there is no discharges from the episiotomy, meaning the episiotomy is healed. So you have to check all this to know that the mother is fine. Then the H is the hormones or the DVT. You have to examine the lower extremities for pain, swelling, warmth or redness, indicating thrombosis. So this one, when we said during our presentation, we noticed that during this examination, you have to let the mother dorsiflex her legs so that you can check for the lower extremities for any pain or swelling at the lower extremities. And the next E is for emotions. You screen for postpartum depression, baby blues, assess bonding, and evaluate support. Yes, because postpartum depression or psychosis is alarming. Some of the women, because of financial issues or marital issues, even some of them, maybe they have 3 boys, and this time around they were expecting a girl, or yes, and they had the same sex. You see, there will be a lot of emotional things going through. So we have to examine for any postpartum psychosis. And if there is any, we have to educate them and encourage them as well. Please, my next sister will continue with the breast and lactation examination. Thank you.
Okay, sisters, good morning. Please, this is Bless and Koda. Please, I'm actually I want to talk about the breast and lactation examination and then the key clinical steps. We all know that breast examination is important because it actually helps assess the mother's adaptation to breastfeeding. And then it also helps us to identify any problems that may actually interfere with successful lactation. So with the breast examination that we are starting from, the examination of the breast actually consists of the 3 main steps. First, you need to inspect the breast, and then after that, you palpate the breast, and then you also assess the colostrum or the milk secretion. So if you look at our slide, you are saying that for the inspection, what are you looking out for when you're actually looking? We are saying that we take note of the shape, the size, the skin changes, vascularity, and nipple integrity, that is cracking, bleeding, or inverted nipple. We don't know when you look, if you pick the shape and then the size of the breast, we look for the shape and size because if you look at the shape and then the size of the mother's breast, it helps us to, or it tells us whether they have changed normally after pregnancy and then childbirth. And then the breast usually becomes actually bigger as they prepare to produce milk. So looking at the shape and then the size also, it also helps you to notify any unusual changes, either with the color or any swelling or anything of that. Then if you look at the skin changes as well, you tend to look for the signs of any redness or swelling of the breast. And then those actually indicate probably inflammation, not probably, sorry, indicate inflammation or infection. And then the next one, we are talking about the vascularity. So the vascularity is actually talking about looking at whether there's a prominent veins being shown on prominent veins actually showing on the mother's breast. That actually shows probably there's increased blood supply to support the breast milk production. And then with the nipple integrity, the reason why we actually look out for the nipple integrity is that we check for the cracks or any bleeding nipples, because that can actually cause pain and actually increase the risk of any infection. And also we look out for whether it is inverted, there's an inverted nipple. That can also make it difficult for the baby to actually latch effectively. So after you're done with the inspection of the breast, you move to palpation. So when you're palpating the woman, the breast actually, what are you intend doing? So after inspection, when you palpate, palpation is performed. So during the palpation, the breasts are gently felt for any generalized firmness or any localized warmth or tenderness or any hard, painful nodules. The reason for palpating the breast, it helps you to actually distinguish any normal breast fullness from abnormal findings, because we know that a lactating breast is usually firm because of the breast milk production. However, when there's a localized warmth and tenderness, it can actually suggest there's infection. And then you also palpate for any hard, painful lump, which may actually indicate a blocked milk duct. Then the next step is colostrum. That is the final step when you're actually assessing the breast for a pepperer woman. So with that, we check the presence of characteristic of the breast secretion and assess the transition from colostrum to transitional milk period, which actually we are saying it occurs after about day 3 to 4. Thank you.
Assessment of the uterine fundus. Technical palpation method. So you have to support the lower uterine segment with one hand. Sister.
Christine, you just finished presentation, so why is the other person? Why are you taking this one? You have a whole lot of people in your group. So hold on, let someone take it.
Please, we have the assessment of the uterine fundus. The technical palpation, that's the technical palpation method. So with this one, you support the lower uterine segment with one hand above the symphysis pubis. Then use the outer edge of the other hand to locate the top of the fundus. So to ensure that the uterus feels hard and well contracted. If soft or bulky, perform immediate gentle fundal massage to express trapped clots and trigger contractions. And then we have thrombotic Rex state in purpurium. That's the hypercoagulable state of pregnancy persists into the postpartum weeks, coupled with immobility, making women highly susceptible to deep vein thrombosis. And then the unilateral leg assessment, you examine both lower extremities systematically. You measure calf circumferences if asymmetry is suspected. You look specifically for localized erythema, localized tenderness or warmth along the venous pathway, and the hormone signs controversy, while traditionally defined as calf pain on the rapid passive ankle dorsiflexing. Modern clinical standards suggest it has low sensitivity or specificity and can dislodge a clot. Prioritize ultrasound diagnostic instead. So with the low-care progression and clinical alarms, we have the types of low-care and then the consecutive days it should last. So we have low-care rubra, that's from day 1 to day 3, the normal duration. We have the color and then characteristics. We have the primary composition, and then we have the clinical alarm indicators, meaning if you find something odd or something opposite the findings, it needs for clinical alarm. So the local rubra starts from day 1 to day 3. And the color or the characteristics consist of deep crimson or bright red intermittent moderate flow with small clots. So it consists of the composition. It consists of erythrocytes, epithelial debris, decidual and fetal membranes. So when the lochia is foul odor, the clots are large like egg size, and then pad soaks less than an hour. You see the pad is soaked less than an hour. It calls for alarm. And then lochia serosa, we start from day 4 to day 10. That one, the color is pinkish brown to pale brownish or red, thin and watery. So it consists of serous exudates, erythrocytes, and leukocytes, and then some of cervical mucus. The clinical alarm, when it is persistent red color beyond the day 4 or purulent exudates, there is the need for alarm. And then the lochia alba starts from day 11 to day 21 going. That's the creamy white, yellowish white, or pale turbid white. There's no odor. And it consists of leukocytes, decidual cells, fat, mucus, and cholesterol, bacteria also. And then clinical alarm is when there's reversal to red discharge, heavy bleeding, there's fever, and there's pelvic pain. So with this lochia alba, when you notice the color is still red and there's bleeding is heavy and she's having fever or there's a complaint of the pelvic, there is a need for alarm and then you need to do further investigation to rule out infections and other diagnosis. Thank you.
So please, I'm Mary Asante, and I'll be presenting on episiotomy and perineal assessment. And if we talk about episiotomy, it's a surgical incision made in the perineum during labor to enlarge the vaginal opening and facilitate delivery of the baby. And also, perineal or perineum is the area of tissues between the vaginal opening and the anus in a woman. So after we have given episiotomy, we need to observe or we need to look out whether the episiotomy we have given it is alien or if there is anything that has occurred. So we have the key clinical observation, things we should look out for after giving episiotomy. First of all, we will look out for sepsis, whether there is any infection, to indicate any infections, to indicate any foul smelling from the discharge, foul smelling discharge from the site, or if there is any severe localized pain at the site. And we also look out for hematoma. We will check whether if the site is tense or if the client is feeling any pain. The client is feeling any pain at the site, or if there is any swelling at on one side of the perineum. And also look out for normal. That is whether the wound is healing or not. So we'll check out for any mild swelling or bruises during the first 2 days. And we also check whether the wound edges are closely closed or if there is no gap between them. And also have the reader scoring system. And the reader scoring system is used to assess the healing of the perineum of an episiotomy or perineal tear. So we always inspect the perineum in a natural same position with light. And the score of each element is from 0 to 3. So with the abbreviation, the R stands for redness, which indicates that there is active capillary engorgement or infection at the site, and E, which also stands for edema, which indicates that there is swelling due to fluid accumulation at the site. And we have another E, which is ecchymosis, which indicate that there's bruises caused by ruptured blood vessels. And we have D, which stands for discharge. And with that one, we will check if there is any serum present at the wound. And we have A for approximation. With that one, we will check if the wound is healing or not, and if the wound edges, are they aligned or they are not aligned. Thank you.
Sisters, please, good morning. My name is Echampo Merita, and I'm presenting on assessment stroke examination of a corporal woman. So we said before you assess a woman, you need some requirements, and that's a trolley. With a trolley, we have the bottom shelf and the top shelf. And we say the top shelf contains items that are very sterile, and the bottom shelf contains items that are not sterile. So with the top shelf, you have your sterile receiver, your gallipot with sterile swabs. You would have your gallipot with Savlon lotion. Then you would have your sterile gloves. Then with the bottom shelf, please, with the bottom shelf, you'd have your examination gloves, your receiver, your sanitary pad, your tape measure, your Macintosh, and your dressing towel. Thank you.
So please, we are moving on to the procedure. I am Patricia Watson. So first of all, you establish rapport and then explain the procedure to the mother and ask her to empty her bladder. You provide privacy and put her in a dorsal position. You wash and dry hands. You examine the hair and scalp to see if there is any scalp pain, redness, itching, or then after that, you then examine the conjunctiva, mouth, nose, and the ears to see if there is any infection, jaundice, anemia. And then we examine the hands, arm, and then check for refill of the fingernail bed. We then examine the breast, and you teach the client self-breast examination. You inspect the abdomen and then palpate the uterus to see if to evaluate the uterine involution. You then measure the fundal height. You examine the back and the sacral region to identify if there is any postpartum pain or maybe there is a sacroiliac joint dysfunction due to the physical strain from labor or maybe epidural administration. You then examine the legs to see if there is any deep vein thrombosis. You wash and dry hands and put on an examination gloves. You then instruct the woman to expose her by flexing legs. You remove the perineal pad using one hand, which I prefer using my right hand to remove the perineal pad. And then you inspect the lochia, vulva, and the perineum. So the lochia, you check for the color and the odor, and then the vulva and the perineum, in case maybe the client had a tear or maybe episiotomy was given, you have to inspect and see whether the wound is healing or maybe it's infected. Then you go for to You tidy the vulva, perineum, and then apply a fresh vulva pad using the other hand. So after that, you clean the vulva and then you apply a new pad there. You remove glove and wash and dry hands. You assist the woman to redress and make her comfortable. You then thank the woman and then communicate your findings to her. You record and report any abnormality findings. Thank you.
Good morning. Please, I'm continuing from our prayer, postpartum guidelines and references. These are where we copied or we did our work from. We got our source of information. So with the organization, this one is also giving us the form of organization, the standard guidelines for postpartum recommendation and focus area. So if you are organizing or you are doing postpartum assessment or examination of a preparatory, these are what we should, how should I say, we should concentrate much on. So when we take the postnatal care guidelines for mothers and newborns, we should ensure that at least 4 postnatal visits are recommended, a minimum hospital stay of 24 hours after vaginal delivery. So for the CS, it's a minimum of 3 days, depending on the condition of our client. Where we should focus on preventive care, the vital screening, newborn health and maternal emotional well-being. Then we come to optimizing postpartum care. This we have to redefine postpartum care as an ongoing process rather than a single 6 weeks check. Early follow-up in the first 3 weeks. First, we knew that postpartum was only after 6 months, or it's only 6 months, but this is telling us that we should ensure that our care that we give to our pregnant woman should be an ongoing process. It shouldn't be just the 6 weeks check. What we should focus on are the hypertension tracking, diabetes screening, contraceptive counseling, and mental health. Then we come to our postnatal care standard and green top guidelines. We should prioritize thromboprophylaxis protocol when we talk about a deep vein thrombosis. So early detection and maternal sepsis should be also, we should concentrate on those one also. So we should also focus on what the low molecular weight, heparin usage, antibiotic treatment parameters, and clinical triage.
Please, group 2, we are done. Any questions or contribution or suggestion? Please, any question for group 2?
Please, sister, please can assessing the PEPRA mother with regards to whether she has family support, whether you know, they all affect her mental state. You know, as we were talking about PEPRA blues and psychosis and all that, you know, they all have a role to play. So assessing the family support and all that, can it be also considered as a clinical assessment for PEPRA mothers?
Please, you mean, can you come back with your question again?
What I'm trying to say is that when you are trying to do your assessment and then you find out, probably it will not be physical assessments, but through your conversations and all that, before you proceed with your physical assessment, finding out if she has family support and all that, could it be considered as part of the clinical assessment that you are doing?
Yes, it's part. I think it can also be part of the emotional assessment too. So you have to talk to any of the family member or the husband to help them as well. Yes, so I think it's part of the clinical assessment, although it's not physical assessment.
So you realize that assessing the emotions, they go beyond you asking questions. Sometimes the observation part does a lot for you. And then you don't also wait till the period time to assess for these emotions. Sometimes you get to know them right from ANC. Those women you've been seeing, you realize that some of them come and they are in one corner. As in, they don't want to mingle with anybody. Forget the ones with pride, the ones who think they are literate, and so they wouldn't want to mingle with the others. But there are some of them genuinely, when they come and then you glance through, you realize that some of them are in a specific corner. They are not mingling. Their face tells you that no, this one isn't okay. So right from there, you can pick them up. Now, if they escape you from there and then they deliver, during delivery, when someone comes and she has no support, don't you see that sometimes they come alone and then even getting people around her becomes a hurdle? And so it is your observation that will even prompt you to get closer before you even start asking questions. You get it? So it shouldn't always be a verbal one. Let's use our eyes to be observing things in our words, and then we'll be able to fish some of these people out. And they are the people who get these blues and then the psychosis, because you realize that nobody is helping them, nobody is with them, and then it looks like they've been sidelined or allowed to be in their own world and all that. The one who asked the question, are you okay?
Yes, madam. Thank you very much.
Group 2, do you have any videos for us? Especially with the human sign and other things. Now, with the human sign, some evidence say that when you use the human sign to detect DVT, and indeed a woman has DVT, the thrombus will move from where it is to, and then travel through the veins into the brain and all that. And so some of the evidence do not approve. But as it stands now, it is the only sign that we can use to get a clue that this woman is at risk of DVT. And then you should also know that the woman sign isn't a final way of diagnosing DVT. Once the woman sign gives you a clue by the woman complaining of pain at the calf and all that, then you go ahead to do further examinations, further tests to actually be able to diagnose that indeed this woman has DVT. And so once you know that there is woman sign, do not go and say, hey, I did a woman sign and then the woman says she's in pain. So right away you go ahead and then you diagnose DVT. I beg, be calming down. And then you also realize that when you are doing examination of the PEPRA woman, it goes beyond the bubble HE. You know, some of the bubble HE, you can't really assess it during the examination. And so we should try to put the bubble HE in a specific clinical assessment task, and then the examination. You know that from the examination you have to do from the head to the toe, but the bubble HE gives you some key areas that they would want you to do or would want you to assess. And then when you are doing the PEPRA examination, especially during exam or even in your wards doing PEPRA examination, you realize that it is not that time that you'll be able to assess the woman's emotions. At that time, the only thing you can do, like I said, is the observation. And then after that, you can just sit and then probe further for the other things that will confirm that indeed this woman has this or that. And so we should take note. Group 2, I asked, do you have videos for us?
This, we posted videos in our presentation, but I think
they're only screenshots. Or they play.
During our discussion, we used WPS. It's played, but I don't know why right now it's not coming through.
Anyway, if there are no further questions, let's move to the next group. So even though the task that I have is saying that you do the perineal care before the legs, I think it's ideal to do everything before doing the perineal care like they said in their procedure. And I think they captured almost everything in the procedure that they projected. So we can go ahead. Those who are still using iPhone, Zoom user, whatever, if you realize that you are off Zoom, I am the one who personally removed you. So take note.
Please, group 3, you can start. She has projected it.
Okay, please. Good morning. Please, we are group 3. We are presenting on position and attachment of baby to breast. I'm Umar Mabaraka. So, Sam, shoot. So I'll start with the objectives. 1, to identify factors influencing breastfeeding position. 2, to identify infant feeding cues. 3, identify breastfeeding positions. Also talk about signs of correct and poor attachment. Then we will discuss benefits of breastfeeding to the mother. Thank you.
Mubaraka, please continue. We are listening.
Good morning. Please, I'm Hannah Ikapa. I'm taking you through the introduction. Human breast milk is the healthiest form of milk for babies. Breastfeeding promotes health and helps to prevent diseases. Successful lactation is determined by early initiation of breastfeeding and continuation of lactation. And again, that is determined by positioning. It should be done exclusively for the first 6 months of life. Getting the right position and attachment that latch is a key to comfortable breastfeeding, experiencing, and thank you.
Please, I'm Jafar Amama Takambala. I'm to continue from where my sister stopped. And that's the objectives. 1, we are to look at how to identify factors influencing breastfeeding positions. 2, identify infant feeding cues. 3, identify breastfeeding positions. 4, talk about signs of correction and talk about signs of correct and poor attachment. 5, discuss benefits of breastfeeding to the mother. So we have factors. So we have factors influencing position. We have the social and family. What is it? Support from social and family network is crucial for success. Workplace environment and economic constraints play a major role in breastfeeding or position. Okay, education. Support from lactation. Education ensure proper techniques. Infant factors. Biological and infant-specific factors influence attachment. We have maternal health. Maternal mental health, diet and emotional status are key. And we have the environment, privacy, and the specific physical position used by the mother. All these factors can influence the positioning We now move to the infant feeding tools. Baby hunger. Natural non-verbal signals babies use to communicate when they are ready to eat. So these are factors that baby use to communicate to their mothers when they want, and they are natural. So we have 1, bringing hands to mouth. 2, we have lip smacking or licking. 3, we have rooting reflex. 4, we have suckling movements. 5, we have nuzzling. 6, we have stirring. 7, we have fusing. And then 8, we have crying.
Okay, please, I'll be taking the types of positioning.
Hello. Please, I'm Mary Asamoah. I will be presenting on types of positioning. We have various types of positioning. First, we have the CODeL hold, and this, you hold the infant in upright position on mother's lap. Infant head is crook of mother's elbow on the same side, close to the breast. The neck is slightly extended. Infant's ear, shoulder and hips in straight line, tummy to tummy, chest to chest of the mother. And we have cross CODeL position. This is the same as the CODeL position, but just the opposite hand was used to support the infant, and the same side hand was used to hold the breast. And we have the football hold. The infant's legs are under mother's arm, with hand at the base of the head and neck. Use pillows. Help infants in latching on, and when football hold is needed. Through cesarean birth, to see the line of position, large babies, small baby, or infant is sleeping. Please, the next line. We have the side lying position. With this, baby lying on one side, you use pillows, tummy to tummy, baby's mouth in line with nipple. And then we have the laid back position, the standing position. This one is not necessary, but we use this if baby is crying. Please, the next step. And feeding position for twins. We have double rugby or football hold. Provides an upright line for both. And we have the double CODeL hold. Both babies lie across the lap of the mother. Please, next line.
Class is the next attention.
Please, enumerate. I'll be taking you through the signs of correct attachment. 1, we have mouth open wide. 2, lower lips is turned outside. 3, chin touching the breast, which means the baby is well attached to the breast. 4, black part of breast not visible below lip. 5, milk collecting that are inside baby's tongue. 6, tongue under the tooth. 7, no pain for the mother. When the mother is breastfeeding the baby well, there's no pain in milk. 8, rounded teeth. The next one is for when you are breastfeeding the baby and the attachment is not well. These are some of the things you see. 1, mouth is not wide open. When you are breastfeeding the baby, you see that the mouth is not wide open when breastfeeding the baby. 2, chin is away from the breast. So when the mother's position and the baby's position is not well, the chin will be away from the breast when the mother is feeding the baby. 3, baby is suckling only nipple. So when you don't put the baby well to the breast, you see that he or she will only be suckling from the nipple. 4, most black portion of the breast is outside. So when the baby is not well attached to the breast, you see that instead of all the areola to be in the baby's mouth, you see that only part of the baby's mouth is in the breast. 5, tongue away from the teeth. So when you are breastfeeding the baby well and the position is incorrect, you see that the tongue is away from the teeth. We also have how to detect for lactate. Mother feels pain during breastfeeding the baby. 2, you hear some sound by the mother. 3, baby appears eager to suck but unsatisfied. So when you detect there is a poor lactating, you see that the baby will feel the urge to suck, but because the breast is not well attached, you see that the baby will feel eager to suck, but after the suckling, there will be no satisfaction after breastfeeding the baby. Thank you.
I'm in a person of Safiato Aziz Pepra, and I'll be taking importance of proper technique. The first one is milk transfer. Ensures efficient milk transfer and sufficient milk supply. The second one is baby's health. Results in a happy, contented baby who is well fed. The third one is mother's comfort. Helps the mother relax and prevents her from becoming sore. Please, the next slide. Signs of success within the first weeks. 1 to 2, wet diapers during the first few days. 6 to 8 days, wet cloth diapers. That's 5 to 6 disposable per 24 hours. The third one, at least 2 to 5 bowel movements every 24 hours. Within the 6 to 10 days, feeding per 24. Within 6 to 10 feedings per 24 hours. Then there should be audible baby swallowing sounds. Weight gain of 120 to 210 grams per week after day 4. Please, next slide.
Benefits for the mother. 1. Delayed return of fertility. 2. Special satisfaction in meeting baby's needs. 3. I can't see well.
Lower risks of premenopausal breast cancer.
Okay, thank you. Lower risks of premenopausal breast cancer. Lower risks of postpartum hemorrhage, which uterus contraction. Items needed: basin, jar of clean water, soap dish and soap, tissue and diaper. So before breastfeeding, you need to wash your hands before you can start breastfeeding. Thank you.
Okay, so please, we are on the sisters. Please, my name is Selina Amasa, and I'm presenting on the procedures and the steps that we follow to breastfeed a child. So the first one is establish rapport and explain procedure to the client. You greet the client and then you explain what procedure you are going to help the client to do. And then make sure that the client will wash her hand and then she will be seated in a very comfortable position. For instance, if the person is a very short person, and you can help with a stool so that the person can sit comfortably with her legs placed on the stool. And C, ensure baby is dry and comfortable. And before breastfeeding, you can also check the baby's diaper to see if the baby has pooped or weed and then urinated. And then you have to change the baby's diaper before breastfeeding is done. And then you have to wash your hands, dry them, and sit by the client. That's the fourth one. So the fifth one is you allow the baby's head to rest in the crooks of the client's elbow, as displayed by the picture beside it. The baby's head will be placed on the mother's uh, elbow. That is the crook area. So the next one is you allow the baby's buttocks to rest in the client's palm while supporting baby's back. All these positions will be achievable if the client is seated comfortably. So the next one will be you assist the client to ensure that the baby's shoulders and hips are in alignment. If the mother is seated comfortably, the baby will be placed in such a way that the baby's head and the baby's head and the back will be in alignment as stated in the point. And then you assist, the next one will be help client to position baby so that the abdomen touches the client's abdomen. And then the next one is you assist to adjust the baby's position to enable baby's chin to touch the breast. And then you teach the client to elicit the rooting reflex. So the rooting reflex, we know that you can elicit it by, and you can use your your index finger to touch the lip of the baby's, touch close to the baby's lip. In so doing, the baby will automatically open his or her mouth. That is the eliciting the rooting reflex. And then you assist client to insert the nipple and areola of the breast into the client's into baby's in breast. Sorry, you assist client to insert the nipple and areola of the breast into baby's well-opened mouth. Mind you, we are putting the areola together with the nipple in the baby's mouth, not only the nipple. So in cases where the baby can't, you assist the mother by pushing part of the areola into the baby's mouth. And then you instruct clients to admire and talk to baby as it suckles. So when breastfeeding is going on, you can encourage the mother to talk to the baby, sing to the baby, or say praises, words of praises to the baby. And also, you educate clients to allow a baby to empty one breast before offering the other. Most of the times, our mothers advise always say that the breast one contains water and one contains uh, food, but which is not so. We all know that the breast milk contains the breast milk contains does not contain only water. So we encourage the mother to uh, introduce one breast to the baby. Make sure that breast is empty before we let her continue breastfeeding with the other breast. Allow baby to release the breast after feeding. When baby is suckling the breast, you have to make sure not to remove the breast from the baby's mouth. Let the baby in itself remove its mouth from the mother's breast when the baby is done feeding. And then you educate the client to wind the baby after feeding. Sometimes when the baby is feeding, sometimes they inhale a lot of air, making their abdomen kind of tender, thin. So after feeding, you can put the baby in a prone position on the mother's lap and you gently tap the baby's back so the baby brings out air or belch, yes, please. And then the last one is you record and report procedure after breastfeeding is done successfully. Then you record every note and every details into the nurse's notes. Thank you.
Hello, sisters. Please,
Please,
I'm
the
Mary
next page.
Samoa.
Let's start. Please, my colleague will continue.
Good morning, please. Please, I'm Obinna Retain. I'm continuing from here, my sister, in conclusion. How establishing proper position and attachment is a primary responsibility for a breastfeeding mother. It is a lens so that requires patience, practice, and a strong support system. Mastering these techniques ensures efficient milk transfer, protect the mother from discomfort, and fosters a successful long-term breastfeeding experience. Ultimately, providing the right position and attachment is the greatest gift a mother can give her baby, laying the foundation for a happy and thriving child.
Good afternoon, sister. Please, I've come again. I'm Mary Samoa. I want one of my group members to be a pepper woman for me so that I can demonstrate how to breastfeed, fix baby to breast.
Sister Mary, please hold on. There's a video at the end. Yes, there's a video. Please play the video for us.
Let's demonstrate before the video. Please, Mubaraka, I want you to be my pepper woman.
Yeah, what?
So, Madam Mubaraka, you are welcome.
Thank you, Madam Nurse.
Please have a comfortable seat.
Okay.
And let me provide privacy to you.
Okay.
Please, I'm here to educate you on position and fixing baby to breast. First of all, I have my items like diaper, basin, tissue, and a jug of water. So, Madam Mubaraka, please wash and dry your hands for me. Read this. Let me sit beside you. First of all, you demonstrate to me on how you breastfeed your baby before you continue.
Okay. Madam Nurse, please, normally when I sit, I'll carry my baby and make sure all my breast is inside the mouth and she suckles well.
So you position and just breastfeed like this. Okay. Can I have your baby?
Okay.
We are going to learn how to position the baby.
Okay.
And the reflexes that you need to check if the baby really needs to feed.
Okay, madam. So the way I'm doing it is not right, eh?
It's not right.
Okay, thank you.
So I will educate you on position and attachment or fixing baby to breast. So whenever you pick your baby, you need to check if her diaper is soiled. And if the diaper is soiled, they don't suck well. And if it is soiled, you need to change it.
Okay.
Before you start, you need to wash your hands as we did. You position or bring. You position your baby with her buttocks on your palm. And then the occiput should be on the hook of your elbow. Then you bring the baby abdomen to your abdomen. Make sure the hips is in alignment with the shoulder. And make sure the chin touches the breast.
Okay.
Please, I'm coming.
Can we watch the video? You are delaying us. I don't know if it's the network. Let's watch the video, please. The video play. Let's see. I think that you don't necessarily have to insert the video in the slides. When you get the video link, you can keep it so that after presentation, you quickly switch to the video link and then share the video with us. I think it will be more effective than putting it in the slides. Right, so you should bear in mind that this is a PEPRA woman, so it can be that the woman is on the ward. You don't necessarily have to put all of them in a certain position. A woman can decide to be on her bed, sit on her bed, or lie on her bed, and that is why we allow the woman to choose a desired position. So you don't always have to see that sit down. It's breastfeeding like you presented. It's not always about sitting. There is lying and all that, which you can let the woman assume to breastfeed comfortably. Can I see the tags that you projected? The component task. So you have to insert the fact that you need to let the woman empty her bladder. As we all know that during perperium, bladder emptying is an important component of the perperium. And so forget the fact that it will interrupt with the procedure. It also aid with your uterine contraction and then the involution. And then you said what you perform hand hygiene and ensure the woman does same. Okay, so client washes her hands. Okay. Then you allow the woman to choose a preferred position or a desired position. And so you are not putting the client in a comfortable position. You are letting her or helping her choose a comfortable position or a preferred position. And you ensure that the baby is dry, yes. And then you make sure that, yes, you sit beside the client. Because also to help her position the baby. You cannot stand, you have to sit. And then you said what? You allow the baby's head to rest in the ears. Okay. Then the buttocks will be in the woman's palm. Then the abdomen will be touching the baby's abdomen should be touching the mother's abdomen. The shoulders and then the lower limbs should be aligned. That is why you put the occiput at the crooked part of the elbow. Then the baby will be aligned on the mother's hand with the buttocks in the palm, and then the baby facing the mother with the abdomen touching the mother's abdomen. Then you said what? You assist clients. Okay, so the alignment is the abdomen touching abdomen. Adjust baby's position to enable baby's chin to touch. Okay. And then you teach elicit routine. Teach client to elicit routine yes. And then you assist to the client to insert nipple and areola, most parts of the areola of the breast into the baby's well open. You instruct the woman to admire and talk to the baby as it suckles. Okay. Then you allow baby to release the breast after feeding and avoid forceful. So when you finish, you teach the woman how to break a wound after feeding. And then you remember that at the bottom of every procedure, there are some bonus points that you need to consider. So you need to express appreciation. After that, remember to perform hand hygiene. You have held the baby, you have held the mother. You and I know that as part of our profession, touching, before touching and after touching, you need to perform hand hygiene. Then after that, you record it in the maternal and child health record. And if you are there with a senior person and there is something that you saw, you need to report findings to the officer in charge. All right. So the next group, I think we have some minutes. Let's see. Thank you, group 3.
Hello, sister. Please,
yes.
The rest of the group members' name wasn't captured in the PowerPoint. So we will do that and then we will send it as soon as possible.
Because me, I've already taken note of those who contributed.
Yes, please.
Did they contribute?
Please, yes, sister, we all did. Yes, me, for instance, I contributed, but my name was in part.
So you are speaking for yourself. You are speaking for the others.
No, we are for all of us, sister.
You, I've heard you. Group 4, let's
okay,
hear
thank
you.
you. Thank you, sister.
I forgot to add that if you are putting your client in a certain position or you are teaching them how to adapt to certain positions in their homes, make sure that the chairs they are using has a back. If the chair has low back, they should place the stools or the chairs close to a wall so that they have a place to lay their back. And then if they are to support their legs with the stool, the idea isn't only about the comfortability. You should make sure that the legs are on a stool in such a way that the angle between the thigh and then the abdomen is 90 degrees. That is how to make sure that the woman is in an upright position and not just putting any chair or any stool to support the limbs. Before we are waiting for you to share your screen. For normal no school and tea. Tea I will be
Sister, please, I'm here. I'm waiting for their presentation. They haven't sent yet.
Okay.
Please, group 4, kindly send your work.
Group 4 is not ready. Group 5 should come.
Please, group 6, if we are ready, kindly send your presentation, or you can project as well. Group 6.
So please, group 6, our work is not on PowerPoint for now.
Your microphone is muted. Say the co-host has muted you.
Sisters, please, aside group 5 and 6, if any group is ready, kindly present why. We are begging you.
Sister, please, we are sorry. Can you give the class up to next week? We'll put ourselves together and do a good presentation for you, please.
Let's call it a day. We'll meet in the afternoon. Do not come and repeat this one in my Peperium class. Yes, sir, you give me a different notion altogether, and then I'll be tempted to do what you are not even expecting me to do. All right.
Len. What's that? Hello.
Red no tap so bi. So leave meeting, leave. Tap the red, tap it well.
I'm on you. Who's anyone was say what did you tell the you money didn't tell again. I'm not thinking it. Come on. Yeah. President died.
Hello. Snapchat. You are seriously dating or Snapchat or Kwana Budin. Star Grace, please mute yourself and we beg.
Mama.
Light on. I want to stop. I'm going to charge now. Now me charge me phone. There you me charge more charge. More charge me dem who can me father la. Me wa charge o me dem who. We can pay the charging terminal. I say nipa ebi rama for the continue nipa o me charge phone. Is it be an we na me be fi no dey hen me be fi me charge. What dey buy? It be an. Mo the carpet na sebo. Carpet na.